All right, thank you everyone for joining the today's birth seminar. Today's speaker probably doesn't need any introductions, but before I hand it over to him, let me remind you that the seminar today, the talk today, will be recorded, and you will, if you're a registered participant, you will receive a link to the recording as well as to the slides, and so. When you're joining the meeting, you're already muted, but the speaker has agreed for you. If you have questions, just unmute yourself and ask the question. And you can also type in the question in the chat window, and I will monitor it for you. So without further ado, so today we are lucky to have Dr. Matthew Ferrari, who is a professor of biology as well as the director of the Center of Infectious Disease in Dynamics at Huck Institute. And he's also a Huck Chair in Global Health and also the Eberly Distinguished Scholar in Global Health. He has a very long list of research interests, including population ecology, computational and mathematical biology, and public health. So his group works on a variety of projects, which includes modeling vaccine impact, especially I think around the measles vaccines, and I'm assuming that he's going to talk a little bit more about those. So Matt, take it away.
All right. First, let me get the talk up before I start. We're all set. You can see it. Good. All right. All right. Yeah. So thanks everybody. Thanks for the opportunity to be here and to speak. Um, I'm going to do a tour of a variety of topics. I sort of use this invitation as an opportunity to kind of think about some of the things that I've learned that I wish I had known before about what what vaccination and vaccination coverage and vaccination impact really are. They seem like rather easy things to say, but from a practical standpoint, operational standpoint, from a modeling standpoint, and measurement standpoint, there are all kinds of challenges. And so I'm going to use this as an opportunity to sort of go through some of those things. And as you said, you're welcome to interrupt me, and we can go off on all kinds of tangents. Somewhere in here, I think I have a note to myself to say, right? Part of the reason that I think I will probably belabor some of these points, maybe I'll get to this in my script, but I'm going to belabor some sort of classic points, both because I think it's important, and because we all have an individual and personal experience with vaccination. And so many of us have the experience that we know as individuals or as parents or as community members. And so we have a perception and an understanding of what vaccination is and what vaccination means, that makes it hard for us to step away and look at vaccination objectively, and experience and evaluate vaccination from the perspective of a scientist. And so again, if you have questions about that as we go through, as I said, just interrupt me, and I'm always excited and interested to learn new perspectives as we go through on tangents for things like that. All right. As was mentioned at the start, a lot of my focus is on measles, and I'm going to largely present my view of vaccination in the context of measles, and I'll use, I think, exclusively examples of measles, but many of the things and the challenges I'm going to talk about are kind of agnostic to measles versus any other thing. I've been working on the measles epidemiology, surveillance, and vaccination program evaluation for about 20 years. This is a great CDC infographic that I use all the time, right? Measles isn't just a little rash. It's a big deal globally. It's increasingly in the news in the United States, but I think to put things into, start into meaningful context, right? In under-resourced areas, measles can result in death of 1 to 5% of children under 5 who become infected. And despite the fact that we've done enormous good in vaccinating children around the world, measles still results in 130,000 childhood deaths under 5 every year. So that's 300 to 400 children dying of measles every day, right? So this is a serious and significant public health problem globally. Um, it's been quite a juxtaposition to see the shift in headlines over the last year or so, proclaiming the dramatic success of global vaccination programs, millions and millions of lives saved, all these great things, right? To really naive researchers calling for the global eradication of measles and rubella. This was a very ill-timed article that I wrote and that was literally accepted to be published on the 19th of January, 2025. Um, to the resurgence in the United States and across North America and the loss of measles and rubella, conceivably rubella elimination for the entire Western Hemisphere. Right. So things have vaccination is a great thing. Vaccines are a great thing. They've done a lot of good. But I think it's important that we take a broad view of how these programs work around the world, how they're developing, how they've what their limitations are, and how we can bring some of that to bear both locally and globally. Right. So um, the measles vaccine itself, fantastic vaccine, enormously safe and effective. We're not going to get into much on that point now. I'm going to today talk largely about measles per se. I might mention measles and rubella a little bit. I've done a lot of work on rubella, and I'm quite excited to talk about that. But I'm not going to be talking about MMR. And the reason for that is that in the low and middle income countries that are largely dependent on external funding to maintain their vaccination programs, they use either measles only or measles and rubella vaccines. Um, and this picture here is from a campaign to introduce the rubella vaccination in Sudan. That's changing. We're now adding rubella into all countries in the world, but that progression has been changing over time. Mumps right now is not considered cost effective. The burden of disease attributable to mumps is comparatively low globally, and the external funders that are providing the money to make these changes in additions to the to global vaccination programs just feel that their money is better spent on other public health priorities. And so that's why MMR has not been the predominant vaccination that we're using in low middle income countries, right? So those are the vaccines. The vaccines themselves aren't enough, right? Vaccination is the important thing, right? Vaccination is getting these things into kids' arms, and that's largely been the biggest challenge and the biggest issue. And so I'm going to spend some time going through some points on how we think about vaccination. Right. So for measles, we use three kinds of vaccination programs globally that largely fall into these three buckets. I'm going to start with routine immunization, and we'll get into the other two as we go along. Um, Routine immunization is what most people on the call will probably be familiar with. These are well child visits. Parents, disproportionately moms, bring their kids in at specific target ages for a first and a second dose. And in places where measles is endemic, these doses are done earlier because while the vaccine is more effective in older kids, kids under 12 months are at particularly high risk of measles mortality. So we disproportionately give the vaccine earlier in high risk areas. And I'm going to walk through a little bit of the logic of this here in the next couple of slides. All right. So this is a schematic. So consider a population with age on the x-axis, population size on the y-axis. It's mostly kids, fewer adults, right? So that's the total population. Um, Babies have passive maternal antibodies against measles if their mom was immune. So that's shown in blue. So those are babies that are protected, but those passive antibodies wane over time. They protect the baby from infection, but they also block the vaccine. So kids that receive a vaccine, if they're still in the blue category, don't have long-term immunity, right? If we vaccinate at a given age, some kids are still going to have those maternal antibodies, meaning that their dose is going to fail. And so that gray area with the overlap, we call that primary vaccine failure. So the vaccine was given to somebody who didn't develop a response, and they will, when their maternal antibodies wane, they will then be unprotected and will remain unprotected unless they're vaccinated later. right? Um, Vaccinating later at an older age reduces the primary failure rate for individuals, which is great, but it leaves more babies at risk, and babies, if infected, are at higher risk of severe outcomes. And since there are usually more babies and children than there are adults in low and middle income countries, then later vaccination leaves us with a larger proportion or a larger fraction of the population that is susceptible. And referring to the schematic on the right, since the indirect risk to unvaccinated people, whether they're babies or otherwise, is proportional to the fraction that's unvaccinated, just a change in the age target, just moving the even if you vaccinate everybody, just a change in the age target with the same coverage can affect the dynamics of transmission overall because we now have a larger fraction of the population that is non-immune. Right? So what can we do? Well, we can vaccinate earlier. That's great. That protects all the babies who are most at risk of severe disease, but it increases the primary failure rate, right? So even in a world where we have 100% vaccination, it's hard or impossible to get to 100% immunization with only one dose of vaccine, right? So this is why for measles, we use a second dose. The second dose is critical to making up the difference, and the timing of those doses is then tailored to the given risk setting. In the US, we use the later dosing, so later first dose and later second dose, because measles has been eliminated in the United States, or until recently eliminated. And so the baseline risk to babies has been small, and so we're willing to accept that risk to the youngest so that we can get the benefits, we can get more out of each dose, right? But in endemic countries, they tend to give their first dose at younger ages, at 9 months, so that more infants are immune. And then they also have to give their second dose a little bit earlier, right? So the purpose of walking through this is to highlight, right, that even with 100% vaccination coverage, the impact of vaccination at the population scale is going to be a function of when that is delivered, right? And then from a measurement standpoint, the way that we measure coverage as an indicator of immunity is also going to be strongly dependent on how and where across age we measure these things, right? So instead of vaccination happening instantaneously at the target age, everybody brings their kid exactly in at 9 months or 12 months as they're supposed to, right? The reality is that because of logistics and differences in access to care, many kids come in late, right? And so this top figure here, the blue histogram shows results of respondents on the y-axis to a national survey in Malawi indicating their age when they received their first dose of vaccination. Right. And so those kids, many kids got vaccinated later than the target 9 months, right? And that means that those kids are spending more time exposed to potential infection, right? Several more months, several more weeks or months potentially at risk, right? And then the total coverage is rarely 100% as it was in the schematic that I showed earlier, right? Um, and so the coverage we estimate, right, actually depends on the age at which it is measured. So if we measure exactly at 9 months or at 12 months or at later, we get a different answer with respect to coverage, right? Because coverage is in fact the integral of this vaccination rate process over age. So in Malawi, which is recognized as a really high performing vaccination system, right, fewer than 50% of kids are vaccinated with their first dose by the recommended age, right? So if you measure directly at 9 months, you're going to get a much lower number, right, than you would if you chose some later age, right? And in fact, you get a higher number if you measure even later, right? So even though 85% of kids in Malawi probably received their dose by the age of 1 year, right? Where we measure or the sampling frame that we would use in a survey or some measure of vaccination is going to influence the way that we interpret that number, right? And so that previous histogram and all of these were put together by Timos Papadopoulos in a review of 19 demographic surveys. These were conducted by the Demographic and Health Surveys, which I'll return to again later. And these showed, again, really wide variation in the timing of receipt for both the first and the second dose. And another thing that'll come up again later is one of the things that Timos found was that there was a lot of overlap between the kids that received their first dose and the kids that received the second dose. The second dose is disproportionately going to kids that had the first dose, right? Meaning that the true denominator in coverage for the red histograms is actually all the kids that received the first dose, right? So the second dose is a true second dose rather than a second opportunity. These aren't two independent sampling processes of sampling kids, right? And that then will change the way that we interpret the potential immunization that is arising here, because the second dose is really just making up for that primary failure, as opposed to being a true second opportunity that's catching up many of the kids that had missed the routine doses overall, right? Um, so that's routine immunization. In lots of poor countries, it's hard to get to high coverage with routine immunization. Again, this is largely a limitation of access. Measles vaccine has to be kept cold, so facilities in remote areas usually can't vaccinate, and it's a long and expensive trek for moms to bring their kids in on schedule. So sometimes what we do is we bring the vaccines out to the communities in activities called supplemental immunization activities, or SIAs. These address the access issue, but they're heavy and they're expensive to do. And so we usually only do these every several years, leaving long periods of time of increasing risk in between these large campaigns. So right after the campaign, there's tons of immunity in the population, but then that degrades over time, right? And then we go back out and do a big pulsed vaccination again. From a measurement standpoint, SIAs have a defined spatial scale. They're often national, but they're increasingly subnational. And there's all kinds of research and questions in terms of how and where to do subnational and how to do the targeting for that. They also have a defined set of eligible age classes. This is most frequently kids between 9 and 59 months of age. Um, and so, from an evaluation standpoint, these are seemingly easy, right? There's a clear sampling frame, and classical survey methods should be able to estimate coverage really well. But some of the challenge with SIAs is that they are, by design, non-selective of prior vaccination or prior immunity. And so coverage doesn't really tell us what the additional immunity attributable to these campaigns are. So their impact, right, is harder to measure. Their coverage is easier to measure, and they're necessarily redundant. And so the better the routine program is, the higher the coverage of routine immunization, the less marginal benefit and marginal gain you get um, through supplemental campaigns, right? And we're going to get to outbreak response here in a little bit, right? There we go. There we go. Um, uh, I've spent a lot of time with SIAs. There's a lot of excitement about trying to move away from these because they're so expensive, and especially in light of the international funding crisis for development aid. Um, it's really hard to overemphasize how enormous and challenging these activities are. These are beautiful pictures from an artist called Sophie Blackhall, who worked with the Measles and Rubella Initiative to sort of create some promotional materials for their fundraising. But just to put some of these things in context, right? A campaign in Nigeria this last October delivered almost 60 million doses of vaccine over a 1 month period. Right? If you think about that, 60 million doses divided by 30 days, right? Is they're vaccinating 2 million children a day. So they're magnificently complex and big, and there's a huge number of trade-offs in the frequency with which you can carry these things out, the scale of who you can target with these things, and even down to really important considerations about how big the vial is that you pack these doses in, whether you use big vials or small vials. And for those of you that are familiar with some of the topics that come up in things like vaccine hesitancy in the United States, there's a preservative called thimerosal that has been taken out of vaccines in the United States, but it is absolutely essential to the success of these kinds of campaigns because it's required in in multi-dose vials, because you have to continually put a needle into the vial to draw new vaccine up, right? And so current U.S. policy has tied vaccine funding through an organization called Gavi to the elimination of thimerosal from the vaccines that they're using, which again fundamentally changes the operational considerations of these things, right? Because it's we completely unsafe to keep the preservatives out of those vials, but completely infeasible to vaccinate 2 million children a day with products that are packaged in single dose delivery vaccine, single dose needles or single dose vials, right? So again, just an enormous number of challenging operational complexities with these things. Right. Um, and outbreak response, which we'll get to again here in a minute, this is the last resort. And while we can often measure the coverage afterwards, we've shown that the impact of outbreak response is actually far more importantly determined by the speed with which they're carried out and the strong investment in modeling and monitoring and infrastructure for rapid response. Okay, so that's to get through a bunch of sort of big picture about the scope and scale of what we're even talking about when we talk about vaccination. And we can get into what the impact of that is. So it's unquestionable that vaccines have saved millions of lives. This figure here is from a 2024 analysis that we contributed to that estimated that over 150 million children saw their fifth birthday due to the 50-year legacy of the expanded program on immunization. And over the last 50 years, the measles vaccine has been the heads and shoulders most impactful vaccine. It's the yellow in this graphic, and the estimates are about 90 million of the 150 million children whose lives have been saved by vaccination are attributable to measles vaccine. Um, but quantifying the impact of vaccination isn't trivial at all, especially given how poorly things are oftentimes measured in the world. And so you need to do three things. First, you need to measure how much vaccination actually happened, right? That's hard but tractable using the kinds of methods we can teach in the classroom, right? Then you need to measure how much infection and mortality occurred. That's harder, especially because most of this is not directly observable. A large amount of illness and death occurs in the community and isn't measured by the health system, right? And then the hardest part is to figure out how much more infection and mortality might have occurred in the absence of vaccination. And for that, we need some sort of modeling framework that will allow us to make those kinds of projections. So one of the first independent projects that I took on almost a decade and a half ago was to develop a set of statistical methods for World Health Organization to estimate the total burden of measles infection and mortality worldwide. Before that, measles burden was estimated using a demographic model that just sort of multiplied the number of births in a country by the proportion unvaccinated and assumed that a fixed fraction of those that was the same in all countries became infected. But the challenge was that as coverage was increasing in many countries, this algebra meant that all the cases and the deaths had to decline in hand with that, and that individual countries weren't seeing their local dynamics track because they were seeing outbreaks going up and down, and they were seeing all of this variation, but the algebra was telling them that everything should have been working very well. And so there was a lot of conflict there. And so I worked with a faculty member here in the Department of Statistics, John Fricks, and we worked to develop a state space modeling framework using a hierarchical model here, where what we did was we tied the observed trends in clinic-based case surveillance to a time series dynamical model of how we expected the trend in measles cases to progress. And by fitting the observed trend to the modeled trend, we were able to both use the variation from year to year to track and estimate characteristics of the nonlinear feedbacks between increased vaccination and increased cases, right? And to come up with estimates of the underreporting rate that allowed us to then back calculate the number of cases that we assumed or estimated were happening in a community that were not counted by the health system. We published this in 2012, and the methodology was adopted as the standard protocol for the World Health Organization. And because we linked surveillance with this underlying dynamic model of how cases now lead to cases in the future, we got this model of measles transmission that was specific to each individual country. And this allowed us to then generate simulations of that model to look at what the world might have been in the absence of vaccination. And so we were tracking what we thought was the observed number of cases as they were going down over time, but then we were projecting what we thought the number of cases might have been in the absence of vaccination, and then taking the difference between those two things to come up with estimates of the number of cases that were avoided and the number of deaths that were averted um, because of the investment in vaccination. So I think we released the first estimates of this in 2012. Um, we did this again in 2013. Um, and we did it again and again and again. We've done it every year since. And interestingly, when we fit the model, we don't just update the estimates of now, but we refit our estimates of everything into the past. And this was actually an interesting conceptual challenge for policy. It makes, I think, good statistical and scientific sense, which is that each year we get more data, we get more observations of how reported measles cases change as populations grow and vaccination changes. So that's more information, not just about where we are, but how we got here, right? And so it gives us an opportunity to then update our projections of the past, which changes both our measurement of uncertainty in the past and our assessment of those trajectories in the past, right? And so as time has gone on, we've refined that model. We've gotten longer time series, which means more data and allows us to fit more complicated models. And so as time has gone on, we've reduced the uncertainty in the estimates, and we've changed underlying dynamics of the functions that we're using in this model. A new version of this and an algorithm was developed with help from Kirsten Eilertson in the statistics department here as well, that was released in 2019. A couple of other sort of important things have changed along the way. What's now we have the bottom line is the number of cases and deaths number of deaths we think actually happened. The top is our estimate of the number of deaths that would have happened in the absence of vaccination. If you might remember, in the past, these were diverging because populations were growing, and so there are more kids to possibly get sick. But separate analyses that have been done looking at the mortality rates associated with measles have shown that even in countries where measles has been endemic, that mortality rates have themselves been declining over time as there have been increases in the quality of care and access to care, even in poor countries. And so it's reasonable to assume that that fatality rates would be declining over time with the increases in health system infrastructure across all countries. And so this makes our estimate of the number of lives saved smaller, but again, better justified and better supported by the available evidence. We've learned a ton of things over the course of this. We've seen dramatic reductions to measles mortality since year 2000 and since over the 50-year history of the EPI program. Interestingly, this arises from a couple of things. Some of that reduction is due simply to the reduction in cases. There are fewer kids getting sick. But we've also seen reductions in mortality because the overall case fatality rates have been declining, and because the reduction in overall incidence means that every child on average is less exposed to measles and more likely to get exposed at an older age, right? And if you get measles at an older age, you're less likely to have severe complications. So we've actually had this nice positive feedback loop, which is vaccination has reduced cases, that has increased the mean age of infection, right? And as a consequence of that, more kids when they're getting measles at an age where the infection is less likely to lead to severe outcomes, right? So again, we've had this sort of this multiplicative impact of vaccination over time. Right. We've then taken the underlying models that that were fit here and used them to project scenarios to help us understand measles vaccination or perturbations to measles vaccination systems. So we had observations of what happened due to large shocks to vaccination systems due to the West African Ebola outbreak in 2014, as well as the possibility of large disruptions to measles vaccine delivery as a result of COVID-19 shutdowns during the pandemic. So in both of those cases, we were able to then take these models and project what might have happened in the absence of those perturbations, and sometimes to then use that as motivation for continued investment in vaccination programs. In particular, some of the large campaigns that were planned to be canceled because of the pandemic. We were able to argue that we would have expected them to have large impact, and then in fact it was worthwhile to try and continue those campaigns. Particularly a large campaign in Ethiopia that was scheduled in 2020 was carried out despite initial concerns about the interaction between the risks attributable to COVID for those campaigns. Right. So all of those are, that's the impact and potential of vaccination in the best case scenario of prevention, right? But when preventive vaccination is insufficient, then outbreaks happen. And measles comes and goes from communities, and it leads to, we get these large buildups of susceptible individuals in between outbreaks, which means that the subsequent outbreaks, when they occur, are bigger and more severe. And so when outbreaks do happen, then we have to deploy these smaller and lighter targeted reactive vaccination campaigns, which are necessary, but oftentimes inefficient in order to be fast. And to be fast, they need infrastructure protocols and clear policies associated with them. Prior to 2005, which is not that long ago, prior to 2005, the World Health Organization recommended that during measles outbreaks, you should not do reactive vaccination, not vaccinate during an outbreak, right? This is not because of any concerns about the vaccination itself or the vaccines themselves. It was because the kinetics didn't work. It takes several weeks for a child who is vaccinated to become immunized, right? They have to develop an antibody response. And that will take several weeks for them to be protected, right? And the perception was that the effort, money, personnel that was put into detection of an outbreak, mounting a response, vaccinating kids, and then waiting for them to develop immunity over several weeks would be too slow and would take resources away from supportive care for those that were actually infected in the outbreak, right? So the opportunity cost was perceived as being too large, and the monitoring systems were considered to be too poor, right? And part of the reason for that recommendation was that it was based on transmission rates from the pre-vaccination era in Europe and the United States, and concerns that outbreak response in under-resourced settings would be too slow and take too much time away from patient care, too much effort away from patient care. And so in some analysis that we did with Médecins Sans Frontières, Doctors Without Borders, we did review of several outbreak response vaccination campaigns that they did, and quite specifically one that was done in Niger in 2004. And we estimated the transmission rates from contemporary and local data and showed that outbreaks, particularly in vaccinated populations, were progressing much slower and took much longer than was previously assumed based on the historical estimates. Also, MSF did do a reactive vaccination campaign, even that was contraindicated by WHO, and they did this with the approval of the local ministry. But it was delayed by diplomacy because they had to argue against the WHO recommendation. And so the response itself, which is shown in the bars here, didn't start until about 25 weeks into the outbreak. And so it had limited impact in preventing cases, right? Because the outbreak was likely going to end on its own, as all outbreaks do. And so the impact was estimated only to be about an 11% reduction in possible cases. But the barrier here was not the ability to vaccinate, it was the bureaucratic barrier. And had that been broken earlier, then the response could have been much more successful. And so the critical thing was to break down the policy barrier that was preventing the implementation of these activities. And so in starting in 2005 and leading to a restatement of the policy in 2009, a coordinated lobbying effort by a number of organizations brought to bear evidence that suggested a change to WHO policy. And in 2009, WHO codified that vaccination should be used as the first line response, so a complete reversal, right? After having shown that vaccination could be impactful, monitoring systems could detect outbreaks early enough, and they were long enough and slow enough to be able to be impacted by these activities, right? Um, Again, because outbreak response occurs over a short time and within a defined population, then doing post hoc evaluation of coverage is at least conceptually easy, right? But coverage alone doesn't indicate impact. Outbreaks of immunizing infections are self-limiting, and so it's easy to mistake the end of an outbreak as evidence of that impact. And a campaign done too late can have really high coverage and very little impact, right? Which implies a large opportunity cost, right? And so, as I said, we evaluated that with modeling in Niger, but in many settings and for many, a large swath of the operational public health community struggles to understand the black box outputs of dynamical and computational models. And they would like to see things that were slightly more grounded in empirical assessment that they can appreciate a little bit more closely. And so we did this again in 2011. This was work that was done with MSF in Malawi. There was a large measles outbreak in 2010, 2011, and MSF went in and did outbreak response in 8 districts. And these were campaigns that targeted specific ages between 6 months and 10 years, right? And what we did was there were 8 districts where they did vaccination campaigns and all the other districts where they didn't. And we were able to collect data and review the trends in the outbreaks across all of that. We treated the non-targeted ages as conceptual controls within each district, and the non-vaccination districts as comparators to those districts where vaccination was done. So our hypotheses were based on this, was that within the vaccinated districts, the targeted age classes should be lower in proportion of cases after vaccination. So if you're in the age targets, you got vaccinated or you're interacting with kids of your same age, and you should have less risk, right? But we still expected that there should be some reduction in the unvaccinated age classes as well, because there's less measles circulating and there's less transmission happening overall, right? And so these age classes are older and therefore less likely to be susceptible because of prior infection and vaccination. So we were interested in the relative proportion of cases appearing in the vaccinated age classes versus the non-vaccinated age classes, right? And so that's our baseline. And then we compared that, the relative proportion before the outbreak to after the outbreak, right? Excuse me, not outbreak, before the vaccination campaign to after the vaccination campaign. And we said that if the vaccination campaign was effective, we should see a larger reduction in the relative proportion of cases among the age classes that were targeted, right? So again, from before the campaign to after the campaign, right, we should see a larger reduction in the relative proportion of cases among the age class that was targeted, right? And we characterized that in a case ratio, which said that if things were working well, we should see the case ratio or the relative proportion among targeted kids drop below 1 compared to what it was before the outbreak, right? So that's what we were looking for there. And then we recognized that there might be some other dynamics going on. There may be some baseline decline overall. So what we should also do is compare the non-vaccinated districts to the vaccinated districts. And what's shown here in the bars is the variation that we see in this relative reduction from at any given baseline of week of comparison for the districts that had no vaccination. So the gray is like the baseline degree of variation in the relative proportion of cases from before early in the outbreak to late in the outbreak, right? And we compared that against what we saw in the vaccinated categories. And so the vaccinated categories, we thought if the vaccine was impactful, should be much lower. We should have seen a much bigger drop in the relative proportion of cases among the targeted group there, right? And so this gave us a really simple way with some simple and basic algebra, following a really sort of simple set of hypotheses for coming up with an empirical assessment here. And what we found was that only 3 of the 8 districts that were targeted really showed the patterns that we would have expected that would have been consistent with a large impact and reduction in transmission and cases among the age classes that were targeted specifically in this outbreak. And these other these other 5 districts either had very little impact of the vaccine, right, or there was no particular evidence that the patterns we saw there were in any way different from the districts that did not receive an outbreak response campaign overall. Right. All of this has been part of how we continually evaluate and reevaluate the implementation of outbreak response and campaigns, and then therefore feeds back and generates all of these sort of operational questions about how fast do we need to detect in order for things to be effective, which age groups should we be targeting, where and how, right? And can we predict some of these things in advance, right? So this has then led to a series of research questions that are always ongoing and continuing, right? Um, so again, the vaccination coverage that we estimate, right, depends on the age at which we measured. We started with that, right? And so the design of the surveys, et cetera, and the time at which we're measuring. So relative to either planned activities, these SIAs, or these pulsed reactive activities. So these are things that are changing and fluctuating both across age and across time, and we need to understand the kinetics of that in order to come up with reasonable interpretations of the numbers that we're getting, right? Vaccination is also highly variable within populations, both over space and within subgroups. And for simplicity here, I'll just talk about space because operationally that's been the major focus. It's very hard to target subgroups. It's very easy to target districts and counties and towns and things. First, I'm going to quickly clarify a couple of terms. So we refer to administrative coverage as the number that the government gives, right? And disproportionately, that is calculated as the total doses delivered divided by the total population, right? So this is an operational measure, right? We know we gave this many doses. We know our population size is this. Our coverage is that, right? Anybody that's dealt with population sizes and demographies knows that the denominator here is oftentimes poorly understood. And so it's not uncommon for administrative coverage to be greater than 100%, especially in populations that are growing quickly or experiencing internal displacement and migration of folks, et cetera, right? Survey-based coverage, that's the ideal, it's the gold standard. Those are based on probability-based surveys using all the kinds of methodologies that we love. These are great, but right? These are expensive. They're hard for countries to do on their own, and there's an opportunity for cost for them to do that kind of measurement rather than delivery of healthcare. So they're disproportionately supported by external donors and external dollars, right? And so they're done less frequently. There's a program called the Demographic and Health Surveys, which has been a fantastic resource for doing this. They measure all kinds of demographic indicators, including vaccination coverage. And Saki Takahashi here, who's now faculty member at Johns Hopkins, developed some early methodology for fitting general additive models in both space and age based on the vaccination coverage measured at individual cluster locations in these surveys. And stitching them together to come up with large scale regional subnational within country and then regional estimates of vaccination coverage over time. And so this was, some of the first work bringing geospatial methods to the estimation of vaccination coverage over space, which is fantastic. And it gave us this wonderful view of the degree of spatial variability within countries and the continuity across countries. But one of the big challenges was that the surveys are done asynchronously. They're not done in the same year in all countries. And so this figure that Saki published in her paper in 2017, right? Every country is measured in a different year, and so this actually is a composite over about 6 or 7 years worth of surveys to put this together without a formal correction for changes from year to year, right? We then spent a long time working with Edson Utazi and Andy Tatum. At Southampton University, who they run a program called World Pop, and they have a subunit of that called VaxPop that brought together some really fantastic fine scale geospatial methods for estimating vaccination coverage at the fine scale. And so this was moving beyond what Saki did, which was just to interpolate the observed and measured vaccination coverage, but to also now bring in geospatial covariate data, so things like um, uh, uh, urban versus rural and population sizes and a variety of other geospatial covariates to fit individual, these individual models of vaccination coverage to those covariates and bring them all together into these fine scale predictions at the 1 kilometer grid scale, as well as characterizations of the uncertainty here, right? In order to do this, right, what has necessarily had to happen is that we've had to then break these things up now into um, bins of ages, right? And so if you recall, right, the age at which we measure is going to affect the coverage that we end up with, right? And so we oftentimes find this because so many kids are vaccinated late in the game, right? That measurement at the 2 to 5 age category gives us oftentimes a much rosier picture of vaccination coverage than if we were to measure directly at the ages at which kids are inherently targeted or intentionally targeted for their first dose, right? Um, um, so these have been uh, these were a fantastic set of methods to work on, and there's all kinds of cool stuff that arose from that that I'm not going to go into. But one of the big challenges with that is that they're fundamentally are reliant on uh, external donors who are providing the money to do these activities. And the DHS program was itself supported entirely by USAID, which was defunded by the current presidential administration. Thankfully, the funding for the DHS program has been rescued by the Gates Foundation in the short term, not globally, but specifically in critical geographies. So that's great, right? But we were already concerned and worried about the challenge, the problem of only having estimates every couple of years, right? Every 5 to 7 years when these surveys are done in an individual country, and what we might have to do to kind of bridge the gap in between there, right? Rather than just relying on old estimates. And so this is some work that a grad student of mine, Deepak Bhatia, has done to try and bridge the gap there. And we did this before we knew the DHS was being defunded. But he started with looking at, if we take the administrative coverage, which I mentioned is oftentimes greater than 100% because the denominators are poorly measured, and look at its correlation to what is estimated by DHS. And so each dot here is a subnational unit within each of these countries. So these are administrative level 1 units, so state level scale, right? There's basically no correlation between the survey-based coverage that is estimated and the WHO administrative coverage, right? Which implies that while this is available frequently every year for every unit, right? It's not a great proxy for DHS coverage in the short term. We thought that perhaps there might be ways to use better data that is being routinely collected in all of these countries at the subnational level. And particularly, we focused on measles and febrile rash surveillance data. And so we know from dynamical models that as vaccination increases, not only should we see fewer cases, which itself is biased because of differences in reporting rates and access to care, but we should see fewer cases. We should see changes to the characteristics of those cases. So, right, as vaccination coverage increases and prevalence declines, each cases should, on average, be older because there's less measles circulating. It takes longer for each case to manifest. So we should expect to see, right, older mean age of infection in places with higher vaccination coverage, right? We also know that a larger fraction of the suspected cases, kids coming in either with measles or just with febrile rash, right, and first being indicated as a suspected measles case, should have been vaccinated prior. We should see higher rates of vaccine failure in places with more vaccination, right? The extreme case of that should make sense. If 100% of kids are vaccinated, remember the schematic that I showed at the beginning. If 100% of kids are vaccinated, the only kids that can still get measles are kids that are vaccinated and had primary failure. So the proportion of cases that have a prior vaccination history should increase as coverage increases, right? And similarly, a larger fraction of the suspected cases should be attributable to something else. So they should be diagnostic negatives. They come in, they got fever and rash, we do a diagnostic test, and that comes up negative, right? So we have three indicators that are all positively correlated with vaccination coverage, right? And so what DPIT did was to look at the correlation between DHS level vaccination coverage and each of these indicators. Again, there's a very poor correlation with administrative coverage, but there's much higher correlation with the mean age of infection and with prior vaccination coverage and with the proportion that are diagnostically negative. So each of these individual variables themselves have much higher correlation than administrative coverage and are therefore better proxies, right? And if you put them all together in a multivariate model, then there we go. The my screen's blocked by all of your faces. Then the correlation goes up to 0.75. And so actually in a multivariate model, combining all of these variables together based on the surveillance data gets us a predictive model that with correlation of 0.75. And so because surveillance data is collected all the time, every year in all countries, then we can actually use contemporary data that's collected across all countries to come up with now a contemporary estimate where the inputs are all from the same year, and use this now as a mechanism to get us estimates of subnational vaccination coverage, despite the fact that the DHS surveys that would have been done here would never have been done in the same years, right? So again, this now gives us a proxy measure based on surveillance information. Right?
But as a question before you move
Yes.
forward,
Yeah. Yep.
so David is asking
Ah.
whether you can talk a little bit more about the multivariate modeling you used to combine the results. Combine.
Yeah, I can, and I can mostly defer to DPIT and the published paper. But this was a binomial regression. So I mean, on a certain level, this is enormously simple, right? So this is not a geospatial model. So we're not explicitly accounting for the correlation among states that are close to each other in space, but it was there was a random effect for country, right? So there's a specific country level intercept that is fit, and then a universal sorry, what did I say? There's a country level intercept and a universal slope that is fit for each of the three variables here, and I'm going to lose track of the numbers. This was from a country that was fit and trained on 19 countries worth of data, where those 19 countries had at least 2 years of DHS data. And actually, I should clarify this, that what was done was the model was fit to the first instance of the DHS survey, and then used to predict the second instance. So the second instance was held out from the training and used as a true out of sample prediction. And this correlation of 0.75 is the correlation between the measured second vaccination coverage and the out of sample prediction for that. Yep. Thank you. There's all kinds of cool detail there that I glossed over in the interest of time. A last point that I'm just going to try and make really quickly here is that when we're living in a world where we have these multiple sources of vaccination, routine immunization, supplemental activities, and outbreak response, right? One of the challenges here is that vaccination itself, or vaccination coverage, doesn't always correlate very strongly with population immunity, because there are multiple ways that we can sort of mix and match these three things in terms of their estimated coverage across the population. And so when they're all measured independently, right, then we need some sort of assumptions to piece them all together to come up with characterizations of risks in populations. And a study that I was a part of that was done in Zambia took a different approach. And rather than trying to estimate coverage as a population level measure, what they did was they specifically looked at one of these supplemental activities and only looked at the coverage of the kids that were coming in for that, right? So this is distinctly not a representative sample of the population. This is a bias sample only to the kids that are coming in for this campaign, right? But what it specifically did was to highlight the sort of cost effectiveness of these activities. How many of these kids that are coming in have previously been vaccinated? How many of them had previously been vaccinated twice? And what they did was they took blood samples from all these kids as they came in before they were vaccinated, and then they could measure whether or not they already had antibodies, right? So we could see that amongst the youngest kids, half of the kids coming in for vaccination didn't already have antibodies, right? So it took about two doses to get one newly immunized child, right? But amongst the older kids, right, then it took many more doses to reach an unimmunized child, because many of those kids that were coming in were unimmunized, right? And again, the challenge that we're oftentimes faced with is that doing more vaccination in and of itself is sort of almost always good, right? But doing more vaccination is certainly always more costly, right? And increasingly we're looking for efficiencies in these systems, and so a lot of the focus of measurement here is trying to identify where the inefficiencies are in these programs and where are there places that we can cut. And that's not because we don't want to do these vaccination programs themselves; it's because we want to direct, as these programs become better, we want to then direct that funding towards other components of the health sector, right? And so with that, I will say that despite the ill timing of my call for the eradication of measles and rubella a little over a year ago, right? I do think that we still have lots of the tools to achieve these things. Unfortunately, what we don't have in the United States right now is the political will. But and particularly as measles has reestablished in the United States, right? I think we need to look towards many of the places in the world that have been dealing with measles over the last 40 years that we have not been dealing with it, and look to the lessons that have been learned in many of those countries who have been dealing with these contemporary problems, with these novel strategies and novel challenges, and really try and be humble about looking to those parts of the world to ask for help and support and expertise in addressing the developing challenges that we have here in the United States. So with that, I will say thank you to inordinate number of people that contributed to all the things that underlie all of this stuff, and the various folks that have given money and support for these things over the years. And if there's any time left or anybody wants to hang out on the call a little bit longer, I'm happy to take any questions.
Thank you, Matt, for the great talk. We are running out of time, but if there are quick questions, I think you should take the opportunity to ask Dr. Ferrari. Matt, do you mind sharing your email address just in the chat window so that anyone, if wants to get it,
Yep. To find the Zoom window again. Here, I think I have to stop sharing in order to make this happen, in order for me to be able to see the chat window. Yeah. Yep.
Okay, awesome. Yeah.
So, Matt, this is Bernice Hausman from the College of Medicine. Thanks for such a great talk. I'm wondering if you could just reflect a little bit about, I'm just really struck by how the detail and the approach of this. I'm sorry, I just realized my camera was off. Okay, yeah. So I feel like, so much of the conversation in the United States is about people's attitudes and their behaviors. And I'm really struck about how absent that was from your talk, which I think is really great, actually, because I think we focus too much on attitudes and behaviors and not enough about logistics, how we're measuring, what counts as an immunization versus a vaccination, et cetera, all the issues that you raised. And also the difficulties of the logistical difficulties that are put on the global system when actors like the United States decide that thimerosal needs to be removed from all vaccines. We don't necessarily have to go down that rabbit hole because we could be there all day. But so what I want to ask is, can you just talk about how important or how you feel like this particular approach of thinking about vaccines and modeling the success and impact of vaccination and thinking about the various types of programs, can you talk about that in relationship to what we feel like is the predominant global discourse now about attitudes and why maybe we want to shift back to have more emphasis on the kind of stuff that you're doing?
Sure. Yeah. So one thing I will say, right, is that attitudes are enormously important all throughout the world, and everywhere that I've been. We've dealt with things like religious exemptions and and misinformation and and locally charismatic leaders who are telling people not to get vaccinated, right? And I can point to places in all the countries that I've mentioned where those things have been critical issues. Um, but I do think that the disproportionate focus um, on attitudes rather than outcomes has made it hard to sort of find and target strategies that can change the outcomes, right? There are certainly cases where doing really detailed root cause analysis and identifying some of these things is really critical, right? But that is not always the case, and I think that disproportionately, as I said, that's why I said that I would talk about spatial variation rather than demographic or population subgroup variation, right? And that's because in terms of endpoint outcomes, when you're in countries with 50 to 75% routine vaccination coverage, right? Targeting space is way more cost effective than seeking out the people that are the individual people that are choosing not to be vaccinated, right? And from an operational standpoint, right? It's about where do you pre-position resources, where do you place vaccination centers, where do you target education campaigns, right? Those are things that are oftentimes spatially bound, right? Now, in the U.S., perhaps there are other strategies that might be more effective that things like social networks and et cetera, things like that. That again, I think there also are plenty of examples to be done, to be learned, to be taken from from these activities that are done elsewhere, right? Oftentimes, when you're doing pre-planning for these large campaigns, one of the first things you do is you go to the community, you find who the most important community leader is that's well connected to everybody, and you work and you focus on getting them on side, and then that becomes part of your community mobilization effort to make sure that everybody knows that this thing is happening. First of all, that's the most important thing, right? When we look at the reasons for non-vaccination in post-campaign coverage surveys, right? The biggest determinant that jumps out is I didn't know when the campaign, first is I didn't know when the campaign was happening, or I didn't think I was eligible. Right? Those almost always turn out to be the predominant factors, right? And those are people that are movable. Those are people that are willing to get vaccinated. They just didn't know. Somewhere down the line are people that say things like I don't trust or I don't want it, and et cetera. And unfortunately, right, it's this is there's this parallel like with electoral politics, right? We talk about the movable middle versus the hard line on one side or the other, right? You can put huge amounts of resources in trying to get the most ardent of your family members who believes the exact opposite of whatever you believe, right? You can yell at them all Thanksgiving dinner long to change their mind, and they won't, right? but it's the folks that are in the middle whose decision making can be is oftentimes influenced by logistics, opportunity, things like that can be shifted. Where if you can identify what those, what will motivate them, those become the primary things. And so where a lot of the novel activities are shifting in the low middle income setting, right, is tying, is trying to bundle or put that, we talk about baskets, right, putting vaccine in a basket with other interventions. And so identifying where, acute malnutrition is the primary driver for bringing families and parents into health centers. And if you can do that, then you can try and bundle nutritional supplementation with vaccination, and try and get those things correlated, or concern about malaria and bed net distribution or whatever, right? So depending, those kinds of, again, sort of community issues that are oftentimes regionalized, right? And you have large folks in a given spatial unit that are experiencing the same set of risks, right? Then operationally, right, you bring the stuff to that place, right? And space becomes the better and most cost-effective proxy.
Thank you. It's very hard to see those kinds of endeavors coming to the U.S. right now because of the way that, unless states took up those kinds of efforts, right, with public health, because the federal government right now won't.
Yep. That is true.
Well, we ran out of time. Thank you very much for the great talk. And
Yep.
yeah, we'll hopefully see everyone on the next meeting. Bye.
All right. Thanks, everyone. Bye.